Okay, so the commonest causes of iron deficiency that we as gastroenterologists, and in fact this applies to general practice as well, would see are those related to inadequate intake. So nutritional sources, for example, if people don't eat red meat, have iron deficient diets, and of course with the growing popularity of non-meat containing diets, that's something people need to keep in the back of their mind. Impaired absorption of iron, and probably the commonest cause that we would see in the community for that is celiac disease, which affects variably depending on where you come from originally in terms of your family history, about 1 in 150 people. But if you're from Ireland or England or Wales, it could be as high as 1 in 100, 1 in 120. And then there are disorders where there's increased loss of iron, and they're the diseases that classically tend to come with blood loss from the gastrointestinal tract, and that could be anywhere from the top to the bottom. But the commonest causes, obviously, that we're all aware of are those related to lower bowel diseases such as colonic polyps, cancer, inflammatory bowel disease potentially is a cause, sometimes bleeding from vascular anomalies, and from the upper gut as well, diseases such as gastritis, peptic ulcer disease, usually as causes of relatively asymptomatic in the beginning and then gradually more symptomatic iron loss and anaemia. Obviously, if blood loss is torrential, you develop other symptoms with that, but usually what I'm describing is the slow development of iron deficiency due to the chronic diseases that will slowly pop up in practice. The effect of those is that as you develop iron deficiency, it can be very subtle and slow, and you may not even notice any symptoms yourself, but those around you may know that you're slowing down, a bit more lethargic, not thinking as clearly. And then as it becomes more profound, you will be lethargic, feel weak, feel like you have no energy, become pale, and sometimes you can develop shortness of breath and cardiac symptoms as this progresses, ultimately to the point where you may collapse or faint, depending on how much anemia is developed and how quickly. So it can be anything from asymptomatic to profoundly symptomatic, and therefore you need to have a high index of suspicion when you actually looking for this problem, because it doesn't always hit you in the face as an overt clinical presentation. So in terms of the approach to treatment, obviously there are reference ranges for hemoglobin and iron, and restoration of parameters to within what's accepted as a normal, if you like, in inverted commas, reference range is probably what we're aiming for. Often targets need to be individualised, because for some patients they may need more iron restoration therapy than others, but essentially once you're in the normal range, then you've got enough iron. And the analogy I use to describe that is if you're driving around in your car and you have a quarter of a tank of petrol, you can drive around just as efficiently as if you've got a whole tank of petrol. It's just the distance you can go is a bit different. So if you're replacing iron, as long as you've got enough iron on board for cellular metabolism processes and for making hemoglobin, then you're likely to feel perfectly normal. Whether you've got a ferritin of 50, 100, 200 or 300, it doesn't make a lot of difference thereafter. So as long as you return to the normal reference range, and if you know what the patient's pre-morbid levels were, that is, they previously ran at this sort of level, then that's a reasonable range to aim for. So the usual approach for managing iron deficiency when it's picked up in clinical practice is iron is normally absorbed through the gastrointestinal tract. That's where we get all our normal iron from. So there's no harm in actually trying oral iron supplementation first, especially if this is going to be a more chronic, slow sort of restoration back to normal. You've picked it up, there's no major symptoms or problems, so you just want to get it back to normal. And then oral iron administration, of which there are a number of products out there. Probably the key thing to recognise is that we now know that you will get better restoration of iron stores with oral therapy if you give it every second day rather than every day, because iron absorption does reduce if you give iron repletion therapy every day. The body senses it and has mechanisms by which it will reduce iron absorption, so it's better every second day. If that fails, then clearly getting iron stores back to normal can only be accomplished by giving it through parenteral administration, and the commonest route now is via intravenous replacement. Intramuscular injections usually aren't recommended anymore, and intravenous administration, there are a number of products out there and there are recommended dosing regimens for them, and they will fairly rapidly restore iron stores back to a reference range, an appropriate range, so that there's enough iron on board for biological processes to occur. And where you would use intravenous iron without going to oral iron first is usually dictated by the clinical scenario. Probably a good scenario in gastroenterology would be if you've got profound anaemia, you're profoundly iron deficient, and you need to restore the iron very rapidly back to normal to get the hemoglobin up to do some other sort of interventional procedure. That's when you would use intravenous instead of oral. Once you've got inflammatory bowel disease and systemic inflammation, oral iron is not absorbed very well, so restoration of iron status to an appropriate level needs to be accomplished with intravenous iron in that setting, because oral iron won't really work effectively. So any chronic inflammatory condition that's present in a patient will interfere with the ability of iron to be absorbed from the gastrointestinal tract. And also there's some data that suggests that oral iron administration in the setting of inflammatory bowel disease can have some potential off-target unwanted effects, and there's animal data showing some increased risks, for example, of neoplasia in the colon, for example, when oral iron's administered in inflammatory bowel disease. So that's another reason to sort of use intravenous iron replacement in preference to oral in that setting. And again, clinical decisions will need to be made on particular patients depending on all the other factors that are influencing them as well. And some patients, for example, will also be unable to tolerate oral medications because they get side effects from them. And in that group of patients, if you already know they can't tolerate the tablets, then you'd give them intravenous first up in preference to oral if they do need it. So in my practice, I haven't needed to use such high dose sort of replacement, but usually it would be when there's a time sensitivity to getting iron up and ongoing losses. So for example, if the loss of iron or the underlying cause of why the iron deficiency is there is treated and managed, and you simply want to restore iron knowing that there's no further losses, then you can use the standard approaches. If you have ongoing losses, like for example ongoing blood loss from the GI tract, and you know from the previous history of the patient, particularly if you've given them iron, that you'll have to give it again in a short period of time, then in that scenario you might elect to give more iron so that the number of infusions that a patient has to have are reduced. And then that might give you a bigger window in which you can do whatever other procedures or interventions you're planning on doing on dealing with that particular patient's clinical problem anyway. Probably the easiest way to think about high-dose iron therapy and who you would use specifically in gastroenterology, the group most likely to have that as an issue are those probably with active inflammatory bowel disease where it's chronic. People are having repeated presentations, possibly with complications of bleeding and or iron deficiency, and you might want to give them longer windows between infusions. So that group you might choose to use an agent that's licensed for a higher dose sort of administration. There are a range of intravenous iron products available that clinicians can choose from. They will all adequately replace iron dose as you choose. The main difference between them is the potential for there to be less or more protection against changes in phosphate level alterations with iron replacement, and some of the newer products do have that as an advantage. In the long run, whether that proves to be important or not is the subject of ongoing research, and there is a bit of diversity in opinion in the field, but certainly the newer products that have recently been licensed tend to have less hypophosphatemia, which can be associated with symptomatic side effects of iron replacement therapy, and theoretically would therefore have some advantages over other products. But I think the jury's still out on whether one should be preferred over another at this point in time. Other than that, By and large, most patients can be adequately treated with the usual dose up to 1,000 milligram iron replacement therapy. Again, remembering that the human body has as iron stores somewhere between 1 and 2 grams of iron normally. So replacing iron to somewhere between 1 and 2 grams is just restoring things to exactly as they were. So again, 1 gram is enough iron, 2 grams is enough iron. There's not a lot of difference in terms of the effects of iron on hemopoiesis and cellular iron metabolism as long as you've got enough. And so I would say 1 gram of iron most of the time is more than enough. Okay, so in selecting the appropriate iron replacement therapy for a patient, one weighs up all the factors that are driving the current clinical condition, and then one decides on replacement therapy. So whether that be oral, standard dose iron, or high dose iron is driven by unique patient factors in any individual clinical setting, but high dose iron therapies really should be a requirement in a minority of cases. Standard dose intravenous iron replacement should be appropriate and adequate for most individuals, especially those who haven't been able to tolerate oral iron therapy, because by nature of the fact that patients were tried on oral iron therapy, it says that you think that you have enough time to be able to fix a problem slowly, so therefore standard dose intravenous iron therapy will be able to fix a problem much faster than oral iron anyway, so there's no harm in just simply going to that. And the high dose therapies will one only uses when there's a pressing need to restore iron and get hemoglobin up as fast as possible without reverting to the need for a blood transfusion, which is obviously the quickest way to restore hemoglobin. So there's a range of clinical factors that come in to that scenario. So it's all individual. I don't think there's any one fits all sort of approach, but good clinician decision making is required. So the role of the GP in the ascertainment of people with iron deficiency is that they're the first port of call for most patients who've got a clinical problem, and aside from the ones that present to an emergency department because of some more pressing need. So a GP just needs to have a high index of suspicion as to the presence of iron deficiency, knowing that the presentation can be anywhere from asymptomatic presence of low iron stores to low iron stores and anaemia, and then low iron stores, anemia, and clinical symptoms and signs. So the presentation can be difficult at times to pick up. The diagnosis is based on standard blood testing, so checking the hemoglobin, the full blood picture, the iron stores, and then interpretation of that is also dependent on whether there's any other things going on in that patient. For example, chronic inflammation can disturb all those parameters because of the effects that chronic inflammation has on the ability of the body to release iron for metabolic purposes. And so a GP would need to be aware that, for example, in chronic inflammatory conditions, they might find, for example, the ferritin, which is one of the parameters for assessing iron stores, a lot higher than otherwise it really is, because inflammation makes it higher, even though the ferritin isn't reading out on iron in that setting. So there can be some tricky nuances there, and it's when there's a difficulty in deciding is there a clinical problem related to iron that referral to a specialist is appropriate, and which specialist to refer to is really driven by what the clinical conditions the GP is thinking about that relate to the iron deficiency. So, for example, if it was a hematological or blood disorder, well, going to a hematologist makes sense. If they think it's a gastrointestinal disorder, for example, they're contemplating could this be iron deficiency due to bowel cancer, polyps, celiac disease, some other gastrointestinal problem, inflammatory bowel disease where they've got a patient with Crohn's or ulcerative colitis that's having a problem, then they would refer to a gastroenterologist. In any scenario, if the GP is comfortable with iron replacement therapy, then whilst they're referring the patient for a further assessment, there's no harm in actually immediately instituting iron replacement therapy, because they'll be restoring the iron stores to normal, they'll be fixing any anaemia that may be occurring in the setting of iron deficiency, and the patient will feel a lot better. So by the time they get to the specialist you're sending them to, they'll be in a lot better state than if they were simply referred and everything had to be done at a later point in time. With regard to the counselling that a GP would provide for iron deficiency, the most important thing is to tell patients that iron replacement should only be used when iron deficiency is proven. There's no point taking iron supplements if you're not proven to have iron deficiency. Taking more iron than you need has no health benefits, and in fact there is data that it's published that shows that increasing levels of iron in the blood are associated with increased risks for breast cancer and liver cancer, and both of those cancers are very common cancers not only within Australia but globally. So iron replacement for iron deficiency, but not for simply if you're feeling unwell for some reason but haven't had iron deficiency proven.